I would like to welcome you to Competence in Cancer Care, What the Nurse Needs to Know. My name is Amy Ford. I'm an oncology certified nurse, and we are going to discuss a prostate cancer overview. Before we head into the module, we're going to do two little interesting statistics here. Did you know that 1 man in 6 in the United States will be diagnosed with prostate cancer during his lifetime? Did you know that the 5-year relative survival rate is nearly 100%? This 5-year survival rate refers to the percentage of patients who live at least 5 years after their cancer is diagnosed. Of course, many of these people live much longer than 5 years. According to the most recent data, it's very interesting. The 5-year relative survival rate is nearly 100%. The 10-year relative survival rate is 98%. And the 15-year relative survival rate is 91%. Prostate cancer is classified as an adenocarcinoma that begins when normal semen-secreting prostate gland cells mutate into cancer cells. These cancer cells begin to multiply and spread to the surrounding prostate tissue, forming a tumor. Eventually, the tumor may grow large enough to invade nearby organs, such as the seminal vesicles or the rectum, or the tumor cells may develop the ability to travel in the bloodstream and lymphatic system. If we look at the 2012 estimated U.S. cancer cases, other than skin cancer, prostate cancer is the most common cancer in American men. The latest ACS estimates includes about 241,000 new cases of prostate cancer would be diagnosed, and about 28,000 men will die of prostate cancer. The prostate is a part of the male reproductive system that helps make and store seminal fluid. In adult male, a typical prostate is about 3 centimeters long. It's located in the pelvis, under the urinary bladder, and in front of the rectum. The prostate does surround part of the urethra, which is the tube that carries urine from the bladder during urination and during ejaculation. So because of its location, prostate diseases often affect urination, ejaculation, and rarely, but it may, defecation. If we look at the risk factors for prostate cancer, we know that the number one risk factor is age. The older you are, the more likely someone is to be diagnosed with prostate cancer. About 1 in 15 men ages 60 to 69 will develop prostate cancer. More than 65% of all prostate cancers are diagnosed in men over the age of 65. So the average age in the United States is 69 years old. After that age, the chance of developing prostate cancer becomes more common than any other cancer in men or women. Race is another risk factor. We know that African American men are more likely to develop prostate cancer compared with Caucasian men, and they are nearly 2.5 times as likely to die from the disease. Another risk factor is family history or genetic factors. So a man with a father or brother who developed prostate cancer is twice as likely to develop the disease. This risk is further increased if the cancer was diagnosed in family members at a younger age, so if the man was less than 55 years of age, or if it affected 3 or more family members. Smoking is not thought to be a risk factor for low-risk prostate cancer, but if a patient has prostate cancer, it may be a risk factor for an aggressive type of prostate cancer. As well as obesity and body mass index, they are not necessarily linked to being diagnosed with prostate cancer overall, but obese men seem to have a larger blood volume, and they may likely have more aggressive disease if they were to develop prostate cancer. So in order to understand prostate cancer, we have to look at the terminology, and I'm sure you are all familiar with the prostate-specific antigen, or the PSA, and we know that the prostate-specific antigen is a protein produced by prostate cells. It can be detected at low levels in men of all ages, but it increases when the prostate enlarges or becomes inflamed. It's a protein called prostate-specific antigen because it's made almost exclusively by the prostate. And so the PSA test is a way to measure the amount of PSA that is present in someone's blood. And the lower the number, the lower the risk of potentially developing prostate cancer, and the lower the number, the better overall. And you can see here on this table, 0 to 2.5 is low risk, whereas greater than 20 is considered a high risk number. Some other common terminology that is being more researched and studied today is looking at the percent free PSA. We know that the PSA circulates in the bloodstream, and so while it is in the blood, it can either be attached to proteins that are present in the blood, or it can be unattached or free. So it's normal to have both attached and free PSA, and neither of these forms of PSA are considered to be abnormal. So the percent free PSA can be calculated by dividing the amount of free PSA by the total PSA. Typically, men have a percent free PSA above 25%, so between 10 and 25% is considered an intermediate range, and below 10% is considered to be low. So for many years, physicians have been using the absolute value of PSA to determine a man's risk for prostate cancer, or whether his cancer has returned or progressed. And you can just see here, the higher the percentage, the more likely a benign condition. Another terminology that is very commonly used today is the PSA velocity. And what it is it's the rate at which the PSA increases over time, usually a year's worth of time, and it may predict failure to therapy or aggressiveness of disease the faster the PSA rises in that amount of time. And some different studies have now shown that a high PSA velocity may signal a rapidly growing cancer regardless of how high the absolute PSA is. So if we look at prostate cancer symptoms, we know that not everyone experiences symptoms of prostate cancer. Many times, signs of prostate cancer are first detected by a doctor during a routine physical or a routine checkup. Some men, however, will experience changes in urinary or sexual function that might indicate the presence of prostate cancer, and these symptoms might include frequent urination, especially at night, difficulty starting to urinate or holding back urine, weak or an interrupted flow of urine, painful or burning urination, difficulty in having an erection or painful ejaculation, or they may notice blood in the urine or semen. Some late signs and symptoms for developing prostate cancer are back pain, hip pain, lethargy, fatigue, pain or stiffness in the back, hips, or upper thighs. In order to diagnose prostate cancer, several different diagnostic tests can be done. The prostate-specific antigen, or the PSA test, is used mainly to try to find prostate cancer early in men without symptoms, but it's also one of the first tests that's done in men who have symptoms to see if they may have prostate cancer. The PSA test can also be done and is very useful if someone has prostate cancer. It can tell a physician if the prostate cancer may be recurring or if the patient is progressing. Another diagnostic test is the digital rectal exam that the physician will perform at either a yearly physical or at a checkup. Another test is the transrectal ultrasound, or the TRUS. It uses sound waves to make an image of the prostate on a video screen. It's often used during a biopsy to help guide the needles into the right area of the prostate, and you can see here the biopsy is performed with the ultrasound for guidance. 6 specimens from both sides of the prostate are usually taken. And then also, if they believe that the prostate disease is spread, a pelvic MRI and also a bone scan to see if it's gone to the bones and to see if the disease is spread. Specific treatment for prostate cancer will be determined by the physician based on age, overall health and medical history, the extent of the disease, tolerance for specific medications, procedures, or therapies, expectations for the course of the disease, and individual preferences. Different types of treatments may be used, and we'll discuss these further: surgery, chemotherapy, other medications, possibly radiation therapy, or even a combination of some of the treatments may be used. Something that the physicians often use and will go to, and I encourage you to bookmark this website, is the NCCN member institutions, the National Comprehensive Cancer Network, and this website, nccn.org, is a nonprofit organization with an alliance of 21 of the world's leading cancer centers. They are dedicated to improving the quality and effectiveness of care provided to cancer patients. And through their leadership and expertise, they have developed guidelines that they update very regularly. They update them at least once a year, if not twice a year, if there have been major changes in treatment. There's algorithms for each individual tumor site, and it's a great site that helps physicians determine the proper treatment and the standard of care. When a physician is staging a prostate cancer patient, once they have performed the biopsy, on the pathology report, a Gleason score will be reported, and the Gleason grading system was developed by Dr. Gleason. You can see here on the reference back in 1977. What this Gleason grading system accounts for is 5 distinct patterns that prostate tumor cells tend to go through as they change from normal cells to tumor cells. So the Gleason score can range from 1 to 5. Low-grade tumor cells, so those closest to 1, the lower the number the better, tend to look very similar to normal cells. High-grade tumor cells, so closest to 5, have mutated so much that they often barely resemble the normal cells, and you can see the differentiation of the pattern that he developed and what he most commonly saw when he looked at the pathology slides of these prostate cancer patients. So the pathologist will assign a grade to the most common tumor pattern and a second grade to the next most common tumor pattern. It was interesting. Dr. Gleason seemed to find 2 common patterns in most of the prostate cancer pathology specimens that he was reviewing. For example, in this slide here, the most common tumor pattern is a grade 4, and the next most common tumor pattern was grade 5. So when you see a report on a pathology, you will see 4 plus 5 equals 9, and it looks exactly like that on a pathology report. The Gleason grade or the Gleason pattern ranges from 1 to 5, with 5 having the worst prognosis. So you basically add up the first most common pattern and the second most common pattern. So you can have an average range from 2 to 10, with 10 having the worst prognosis. So for example, a Gleason score of 7, it would either say 4 plus 3 or 3 plus 4 equals 7. But we know that if 4 plus 3 is first, then that means there's a more aggressive type of cancer. So there's lots of importance put into the first most common pattern noted on this pathology slide and then the second most common pattern. There's really not much of any difference between the aggressiveness of a Gleason score 9 or 10 tumor. So if we look at prostate cancer staging, we see here stage 1. Prostate cancers are small and have low Gleason scores. They usually grow very slowly and may never cause any symptoms or other health problems. For men without any prostate cancer symptoms who are elderly and or have other serious health problems, active surveillance or watchful waiting may be an approach. Some of these patients may have radiation therapy as reasonable options. Men who are younger and healthy that have stage 1 prostate cancer definitely may have either surgery or radiation therapy as well. Compared with stage 1 prostate cancers, stage 2 cancers that are not treated with surgery or radiation are likely to spread beyond the prostate and cause symptoms. Stage 3 cancers have spread beyond the prostate gland but have not reached the bladder, rectum, lymph nodes, or distant organs. Surgery and radiation therapy may be less likely to work, but it still may be an option for these patients. And then stage 4, we know that the disease then has commonly spread to, you see, the most common metastatic sites: bone, lung, and liver. So when a physician is looking at the different staging, he's looking at the Gleason score, the staging of the tumor, and the patient's PSA. Dr. D'Amico, back in 1998, published an article looking at the cancer risk stratification of patients with prostate cancer and developed these 3 different categories. And so a physician will place a patient either as a low-risk candidate, intermediate risk, or a high-risk patient. Once they have determined the risk stratification, they then will discuss what are all the different treatment options that would be best for this patient. Active surveillance, or the old term we used to use as watchful waiting, this consists of closely monitoring the patient's prostate cancer by performing a PSA test and a digital rectal exam regularly, and that they would treat only if and when the prostate cancer may cause symptoms or show signs of growing. Surgery, such as the radical prostatectomy or the laparoscope, may be used to remove the entire prostate gland completely. Radiation therapy may be an option, which destroys the cancer cells or prevents them from growing. Hormone therapy is definitely an option for patients to remove the male sex hormones and block them from working. This is commonly used with metastatic disease. Chemotherapy is often used. You will see this usually used in metastatic disease as well, and it's more of a latter choice as a treatment option. And then now we have a newer therapy. We have the first cancer vaccine to help treat somebody with a cancer called Provenge or Sipuleucel T, and we will discuss that further. If we look at prostate cancer treatment and surgery as an option, we know that with early stage prostate cancer, either a radical prostatectomy or a laparoscopic prostatectomy may be an option for our patients, as well as cryosurgery. In the radical prostatectomy, the surgeon is making an incision in the skin between the anus and the scrotum. This approach is actually used less often now because the nerves cannot be easily spared and lymph nodes can't be removed. Laparoscopic prostatectomy is more common. The surgeon makes several small incisions through which different instruments or scopes are inserted to remove the prostate. There are some advantage over using the laparoscope than just having a radical prostatectomy. There's usually less blood loss and pain, a shorter hospital stay, and faster recovery time. Cryosurgery is definitely an option for our patients, depending on the staging of the tumor, but we don't have a lot of data to look at the outcomes of cryosurgery. And then with late-stage patients, an orchiectomy, which is removal of the testicles, may be a surgical option. The transurethral resection of the prostate, or a TURP, is a type of prostate surgery that's usually done to relieve moderate to severe urinary symptoms caused by an enlarged prostate. Basically, this is done for helping with enlarged prostates, so you may not even have prostate cancer. You could have maybe BPH or benign prostatic hyperplasia, and this option may be something that a physician would choose. If we look at radiation therapy, you can see here again for early stage and late stage. With early stage therapy, there are different options. External beam radiation therapy is beams of radiation are focused on the prostate gland from a machine outside the body. This type of radiation can be used to try to cure earlier stage cancers or to help relieve symptoms such as bone pain if the cancer has spread to a specific area. The most common type of radiation therapy that's usually being done today is intensity modulated radiation therapy. It's a form of 3D therapy, and the great thing with IMRT is that it helps to spare the most sensitive normal tissue, and it helps shape the beams and aim right at the prostate from several different angles to help minimize toxicities. And we're going to talk about brachytherapy in the next slide. But with late-stage radiation therapy, it's commonly done for palliation, and it's always done if the patient has spinal cord compression. So if we look at brachytherapy for prostate cancer, we know that brachytherapy can also be called seed implantation or interstitial radiation therapy. It uses small radioactive pellets or seeds about the size of a grain of rice, and these seeds or pellets are placed directly into the prostate. It's generally used only in men with early-stage prostate cancer that is relatively slow-growing, so mainly low-grade tumors. If men have had a previous surgery such as the TURP, or for those who already have urinary problems, the risk of side effects may be higher, so brachytherapy may not be as effective in men with large prostate glands as well, because it may not be possible to place the seeds into all of the correct locations. There's usually two types of brachytherapy that can be done. There's low-dose therapy and there's high-dose therapy. In low-dose therapy, the seeds or the pellets are placed into the prostate, and they are left in place to give low dose of radiation for weeks or months. In temporary or high-dose brachytherapy, this is the newer technique that's being used. Catheters are basically placed into the prostate, and what occurs is that a patient will come for about 2 to 3 days of treatment with brachytherapy. So with the low-dose therapy, they may be more radioactive for a longer period of time, and now with the high dose, they are only radioactive when the seeds are placed, but the seeds are then removed after each session, and the patient can complete their brachytherapy in a matter of a few days. Hormone therapy is the standard for management of metastatic prostate cancer. It's also called androgen deprivation therapy, or ADT. The goal is to reduce the level of male hormones called androgens in the body, or to prevent them from reaching prostate cancer cells. The two main androgens are testosterone and dihydrotestosterone. They are mainly made in the testicles, and they stimulate the prostate cancer cells to grow. So lowering the androgen levels or stopping them from getting into the prostate cancer cells often makes the prostate cancer shrink or grow more slowly for a time. Other options that help reduce those levels, once again, a patient could have an orchiectomy, which is surgical castration, which is removal of the testicles. They also may be placed on luteinized hormone-releasing hormone analog, and you see that here medically, that these drugs help lower the amount of testosterone made by the testicles. Treatment with these drugs is sometimes called chemical castration because they lower androgen levels just as well as the orchiectomy. And then also a patient may be receiving a luteinized hormone-releasing hormone antagonist, and they help reduce testosterone levels pretty quickly. As you can see on this slide, there are different types of hormone therapy, and you may be familiar with some of the names that are used, and these are different types of androgen deprivation therapy. Prostate cancer cells, once again, will rely on the testosterone to help them grow, so we're trying to help shut off or cut off the supply of testosterone, causing those cancer cells to die or to grow more slowly. Chemotherapy is sometimes used if prostate cancer has spread outside the prostate gland and hormone therapy isn't working. It's not necessarily a standard treatment for early prostate cancer, but there are some studies looking to see if it could be helpful if given for a short time after surgery. In most cases, the first chemo drug that is given is docetaxel, and it's combined with a steroid such as prednisone, and it's used mainly in a more progressive cancer with prostate, and it may help slow the cancer's growth and reduce the symptoms, hopefully resulting in a better quality of life for the patient. Chemotherapy for prostate cancer is very unlikely to result in a cure. The last type of cancer treatment we're going to review is vaccine therapy. In April of 2010, the FDA approved the first cancer treatment vaccine. This vaccine, called Sipuleucel T or Provenge, is approved for use in some men with metastatic prostate cancer. It's designed to stimulate an immune response to an antigen that is found on most prostate cancer cells. In a clinical trial, Sipuleucel T increased the survival of men with a certain type of metastatic prostate cancer by about 4 months. Unlike some other cancer treatment vaccines that are in development, this vaccine is customized for each patient. It's created by isolating cells of the immune system from a patient's blood through a procedure called apheresis. The antigen-presenting cells are sent back to Dendreon, which is the company that makes this vaccine, where they are cultured with the protein, and this helps stimulate the immune system and enhance antigen presentation. Each patient's cells are returned to the patient's treating physician and infused into the patient. The patients receive 3 treatments, usually 2 weeks apart, with each round of treatment requiring the same manufacturing process. And I think this is just the first of many potential cancer vaccines that we will see being used. With all of the different types of treatments, such as surgery, chemotherapy, radiation therapy, the vaccine therapy, hormone therapy, comes with many different symptoms that can be very toxic for a patient. And you see here it says decreased libido, potential erectile dysfunction. Males may have hot flashes if they're put on chronic hormone therapy. They may have bladder problems, urinary problems, incontinence, fatigue, bone pain. This is very important as the oncology nurse for us to help treat these symptoms, to help our patients have an open dialogue with us. Many men may be embarrassed to discuss their sexual dysfunction or the problems that they may be having, but it is very important to them. And it's important for you as the oncology nurse to have an open mindset to be able to discuss this with them and to ask them open questions where they can feel very comfortable in discussing with you how to help manage these symptoms. This is a slide looking at different devices that might be helpful for men that have sexual dysfunction issues, and you can see here there are different types of devices that can be used. Also, oral medications are very commonly used today to help patients attain and maintain an erection if that is a problem, because this can be definitely a chronic issue that our patients need to know that there are different devices and different medications that might be able to help them. This image was courtesy of oncolink.com, so I would encourage you to go to that website if you would like further information. So what we know is that our patients, the psychosocial dimensions of prostate cancer, there can be many, many issues that our patients feel that they need to talk about, and their emotions need to be discussed, and you as the nurse can be that advocate. It's important if we understand the NCCN guidelines for patients. So the guidelines come out once a year usually for physicians to know treatment algorithms for patients with prostate cancer. The NCCN has developed a guideline for patients and a booklet on prostate cancer. Once again, I recommend that you bookmark nccn.com for you to be able to go to these different guidelines for patients. It's a great booklet that gives lots of answers to the questions that your patients may have. Other psychosocial dimensions of prostate cancer care that we have to consider as the oncology nurse are patients' health-related quality of life, their social quality of life. They have just had potentially a major surgery or a radiation therapy, and they rely on their spouse for spousal support and acceptance. Their bodies may feel different. They may have different types of urinary or sexual dysfunction, and that can be grieved and considered a huge loss for them. They may go through different types of anxiety and depression, and it's important for us to clue in on when those patients have these issues and to be that open source so that they can talk to. Side effects of hormonal therapy: the patients may have extreme fatigue, hot flashes. It would be important for you as the oncology nurse to either refer them to a patient or family support group. If you have a social worker that you're able to work with, that you could refer them to the social worker, but that you would be able to assess if they have any barriers to learning, that you would be able to assess any social relationships that they have where there's maybe been some changes, and looking at their coping mechanisms and skills. The Institute of Medicine back in 2006 issued a report recommending that every cancer patient receive an individualized survivorship care plan that includes guidelines for monitoring and maintaining their health. In response to that report, many groups have now developed various types of cancer plans, and by 2015, it will be a requirement that every cancer patient have a survivorship care plan. It's basically a record of the patient's cancer history and recommendations for follow-up care, and it's very important that the primary doctor would be aware of this and that they would have a copy of the care plan. It's important that we as oncology nurses understand the screening for prostate cancer. If we look at the 2012 American Cancer Society screening guidelines for prostate cancer, a PSA test and a digital rectal exam annually at age 50 with life expectancy of at least 10 years, and men at high risk need to start these screening guidelines at age 45, so particularly if they are African American and if they have a family history, meaning a direct relative, either a parent or a sibling. What do they need to know before a PSA test is done and drawn? Do not ejaculate for 24 hours prior to the PSA screening. Have any type of lab work done prior to the digital rectal exam being performed. Inform the doctor if they're on any types of medications, because this may either artificially elevate or decrease the PSA. In summary, key points for prostate cancer. It's important for us to understand the risk factors, knowing that the top two are the increasing age and being a male, different types of symptoms such as nocturia or urgency, understanding how to diagnose prostate cancer, and having an understanding of the treatments, and especially the psychosocial issues for prostate cancer. Some key web resources for your information that would be great websites for you to do some further study on prostate cancer. Thank you.